Hi, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today we're going to talk about internal resorption. If you haven't had a chance to, please check out the other videos on external resorption, and they will be important in differentiating between the two types of resorption. But today we're going to talk about the internal type. The internal resorptive lesion is a much rarer form of resorptive lesion than the external resorption type. Depending upon who you read, they'll make up maybe 10 or 15% of all resorptive lesions. They're frequently confused with ECIR by my referring dentists. Let's look a little bit more closely at how we can tell the difference. The most important differentiating factor is the etiology. Whereas ECIR, external inflammatory resorption, origins lie in the attachment apparatus of the periodontium, internal resorptive lesions occur as a result of the clastic processes that occur inside the pulp. It's been my experience that most of these internal resorptive problems either recur as a result of physical trauma, such as an injury in the anterior teeth, or a pulp exposure and subsequent restoration. In the restored teeth that I've treated, there often is a history of deep restoration and pulp caps, which appear to be associated with adverse pulp responses. Sometimes the pulp becomes necrotic soon after the event, or pulp cap, or the pulp space may undergo changes over a long period of time. These changes may be calcific changes, or in the case of internal resorption, clastic cells can get activated and slowly the chamber and the canals undergo resorptive remodeling. The responses to such pulp caps are unpredictable, which is why endodontists prefer not to do pulp caps and are very much opposed to them being performed in teeth that are critical to a treatment plan. The defining characteristic of an internal versus external resorptive lesion in a conventional film is while the ECIR radiolucent finding may shift as you change angulation of the image from mesial to distal, the internal resorptive area generally remains constant and does not shift with the change of the angulation. It's also generally a rounder-shaped radiolucent area in the pulp chamber that is quite distinct and has no ghost outline of the pulp chamber like in the ECIR. One of the first signs may be discoloration of the crown, but unlike ECIR, there is no catch at the CEJ when you examine the area with an explorer, because at this point, the resorption is internal and may have not perforated. However, it is possible for the internal resorption to perforate the outside of the tooth, so an opening at the root surface that does not necessarily indicate an ECIR on its own. Once the pulp pathology progresses and the pulp becomes necrotic, it may eventually move to a more classic endodontic pathology model that includes percussive sensitivity in combination with apical radiolucent findings. Depending on the timing and the extent of the resorption, pulp tests performed on these cases either are non-responsive or they can be ambiguous. Again, cbCT imaging is crucial in determining the extent and the position of the resorption. Once detected, every effort should be made to try to perform conventional endodontic treatment as soon as possible. The chamber anatomy may be enlarged, or the canal spaces made larger by the resorptive process. This generally doesn't risk loss of the tooth as long as it's caught early enough. Since the clastic tissues inside the pulp are the source of the problem, the resorption will be arrested by pulp extirpation and conventional endo treatment. Good endodontic technique and proper post-op restoration are usually enough to provide for long-term predictable outcome as long as the physical structure of the tooth and the root is not compromised. Fortunately, most internal resorption cases are caught before they perforate. They are also slow-moving as opposed to ECIR that can advance fairly rapidly. It's important to try to treat the tooth early before the resorption perforates the root surface and causes extensive internal damage that risks loss of the tooth. Should perforation of the root by the resorption occur, we can attempt to treat the tooth conventionally, but the opening on the root surface may compromise canal dryness at the time of obturation and allow for extrusion of filling material out the resorbed area. Once the resorption has perforated the root, especially if the perforation is large, surgical treatment may be the only option to try to seal the area of perforation. Unlike ECIR lesions, which have their origins in the CEJ, externally perforating internal resorption can occur at any point along the root surface, which is, in some instances, may make surgical correction in less accessible areas of the root impractical or impossible. MTA is the current material of choice for root repairs, while other materials such as Geristore may be better suited for areas that are exposed to saliva. Performing this kind of surgery also has a potential for recession or loss of papilla in adjacent teeth. This is especially risky in the aesthetic zone. Sometimes better to consider extraction of the affected tooth and implant replacement rather than risk compromise of the patient's aesthetics by attempting to surgerize the case and risking a poor cosmetic result. Each situation is different and has to be assessed in keeping with the patient's aesthetics and, more importantly, their expectations. Thanks for listening. Remember, when we do the right thing, we both get better. You, the clinician, and your patient. Please join me again when we take another trip beyond the terminus.